So hi everyone, this is Francois de Brantes and I'm Senior Vice President at Signify Health, and here today with Greg Williams from Third Horizon Strategies to talk a little bit about the sad state of mental health and behavioral health treatment in the US. And before we get started, Greg, maybe a few words of introduction.
Thank you for the conversation, Francois, and it's good to be here. I'm Managing Director of Third Horizon Strategies, and we get to convene the Alliance for Addiction Payment Reform. So our work really centers around how to advance value-based principles for addiction recovery services in all sorts of different landscapes and environments across the country.
So let's get into it. There's a report that came out maybe yesterday, today, early September, right before Labor Day, and that just shows the massive increase in the deterioration of mental health for an increasingly large number of individuals in the country, and hitting, of course, harder those who are out of work, who are struggling financially. All of that makes sense. We also know that there's a pretty close link between that mental state and then the potential for increases in substance use disorders. And we're really headed into a nasty storm on that front. It's not as if we're out of the prior storm. So I remind people that behind the very visible current public health epidemic, there is a long-lasting public health pandemic, which is substance use disorders. So let's dive into it. What does it look like today? How bad is it going to get?
I mean, it's hard to know. I think what we do know is that in 2018, we had our peak overdose period. In 2019, we actually were making some progress, and we lost less lives to overdose and addiction in 2019 than we did the year before, which was the first time during the course of the opiate epidemic that had happened in probably over 5 to 8 years. Unfortunately, the early indications from 2020 is by all indications we're going to be back up above 2018 levels in terms of overdose deaths, impacting particular people of color and other communities. And I think that some of the gravest challenges are, the context of so many addiction treatment services, recovery support services, all are premised around community connection, building positive relationships with clinicians and peers and supports in people's communities. And as soon as we were no longer allowed to be together, it really had a deep impact on individuals who are in early recovery and individuals seeking recovery or in need of recovery services. And so certainly the isolation and the physical distancing is very counterintuitive to what we know is an integral part of the recovery process. So I think the only bright side or silver lining, if you will, is people's willingness to adopt technology, the government's willingness to roll back some regulation around prescribing of certain medications and telehealth visitation payment policy. And so hopefully the silver lining in all of this is that some of those transitions in the regulatory framework and the reimbursement framework continue even once the pandemic is gone and people are still able to get connected and get access to some of these services in remote environments.
Yes, and being able to increase the use of telehealth is obviously a big relief for those who need the support. But we also know that fundamentally there are some significant deficiencies in how local delivery systems can manage individuals who have substance use disorders. And again, maybe one of the silver linings from the current public health emergency is the realization by provider organizations, whether they're primary care physician groups, multi-specialty groups, that reliance on the old way of doing business, fee-for-service, has been devastating. And as bad as fee-for-service has been for those who pay for health care, up until now, 2020 has been absolutely terrible for all of the providers who rely on fee-for-service. So that, to me, at least spells that hope for the adoption of alternative payment models. And you mentioned earlier, Third Horizons helped convene the Alliance for Addiction Payment Reform. And initially, when we started working on this, we thought that moving to more of a fixed budget for management of patients was a little too ambitious, maybe a bridge too far. Perhaps not anymore. And I'd like you to kind of both address that, but also I know that you've been doing some work in modeling, creating models that help communities assess the readiness of their network, because you can have the money, but if you don't have the readiness of the local community resources to help manage what is, as you mentioned just a few minutes ago, an increase in the volume of those who need that care, how do we bring these things together?
This is like the largest misnomer I think that a lot of people have around addiction, is when they hear the word rehab or they hear the word treatment, we have this Hollywood image or this finite, perception that essentially that addiction is this acute illness. You go away for a period of days, sometimes months, and you come back and you're cured. And this is this false notion, and many employers purchase services in this same exact way today. We have so many employers who are buying inpatient service after inpatient service, and doing the same thing they've always done, expecting kind of different results. And I think what we need to acknowledge and really smash home for people who don't understand the word addiction treatment or the continuum of care that is involved. This is a chronic health illness, and this requires lots of different kinds of interconnected services across a broad continuum. And so what that looks like is, of course, early intervention and screening in primary care settings, ER settings, of course, assertive engagement and outreach, reaching out to individuals who we know may have a problem but might not be raising their hand that they want to get healthcare services for this condition. And then once somebody is engaged and is willing to participate in a treatment program or a recovery process, it's designing a treatment and recovery plan that takes them on a longitudinal journey for a period of years, not months. And that, of course, is not going to only happen in an inpatient setting. For some patients, that might be a part of it, but that's not going to be the bulk of it. You're going to deliver most of the services that people need in the community, in outpatient settings, in other non-traditional community-based support settings, in peer recovery support meetings, in some housing settings, and some other clinical networks are doing some in-home services and going to people's homes. And so there's a broad constellation of services. And what we know is that if we put people just in an acute setting and there's no follow through afterwards by the system, we're going to recycle a huge segment of that population back through the same acute services. And so the philosophy, the framework is we need to take a look at our spend, take a look at our investments, and start to spread that out for people over a broad continuum. So our work with kind of network readiness is kind of going into communities and what are your gaps? Okay, so you might have an inpatient program. You might even have an intensive outpatient program, but do you have any recovery management? Are any of your primary care doctors doing any work? Do you have any co-location going on in any of your acute care settings or primary care settings? And are you providing any other social or recovery support services to people either in the employment setting or in the community?
Well, and this brings me to probably a really also a germane issue in this environment, which is, I know about a year ago, we looked at the potential positive impact on local delivery systems of re-insourcing behavioral health management, in particular substance use disorders, because a lot of it ends up by going outside of the local delivery system market, if you will, where people work and live for a variety of reasons. Some of it, as you know, is rehab facilities in distant places that people end up by preferring or that they find on Google that aren't necessarily the best. And I'm bringing this up because we know that delivery systems, many hospitals and health systems are really struggling post-pandemic. And we're not, I'm saying post-pandemic, we're still obviously in the middle of this thing. And wouldn't this be, if we were able to effectively restructure the payment, wouldn't this be a way for them to figure out how to close some of those gaps in the local delivery system to try to do a better job managing and bringing back money? And what does that represent?
Yeah, I mean, I think this is one of the last bastions of primary chronic illnesses that most mainstream healthcare organizations don't serve. I have, this idea that if you want to raise a billboard on your local highway or a sign in your local community that says you are the leading provider of healthcare in your local community, whatever that billboard says, and you are not addressing substance use disorders, then that is false advertising, because this is happening to 20 million Americans. This is happening to 1 in 10 and their families. So you're looking at 2 and 3 in 10 people being impacted by this who you are serving. That is up above heart disease and not above heart, almost to diabetes. It is above heart disease and all cancers combined. So when you think about scale of how many people are impacted, this is the number one issue. And people, health systems will acknowledge that more than 50% of their emergency visits are related to alcohol or other drugs. Primary care doctors will admit that alcohol or other drugs is a driving force for so many of their patients in their health outcomes, but they just don't feel equipped and they don't feel like they have the right tools. And part of that is there just haven't been the right incentives to get them to want to work on this issue. We funded it from sideways, different pathways. We've carved it out. We've separated it from the institutions that they operate in. And so we've, by design, created this philosophy that the brain isn't part of the body, and that's dealt with over there and not where people are actually presenting. And so it's just a great point in that the volume of services is hundreds and hundreds of millions of dollars and billions of dollars. I mean, today it's a $35 billion industry. Tomorrow it probably should be a $350 billion part of healthcare. Because it's so integral to wellness and health. And so if you're not positioning your organization for that revenue stream and delivering this service, especially in a value context, we know it drives down total cost of care. And so it's a huge opportunity for anybody who wants to think about how do they better serve their community. This issue is at the top of the list. Not to mention, last word is, it's the leading cause of death in your community for those under 50. I mean, bar none, every community across America, it is the leading cause of death for those under 50. And so that makes it even more important.
Right. But if I'm a hospital or health system, local delivery system, and I, in fact, just on a call with someone looking into all of the different value-based payment arrangements that physicians are increasingly asking of their payers because they want greater stability in revenue. And we know that a different payment modality to manage in a more comprehensive way addiction plus co-occurring mental health and physical health can create a very big budget on a per capita basis. That seems like pretty strong revenue. And so if you're a hospital or health system, what's holding you back? Why aren't you? I mean, I was reviewing some numbers this morning, and it's $14,000, $15,000, $16,000, and that's the median. Obviously, there's huge variation. We know that for some health plans, it's upwards of $20,000, $25,000 per year for these individuals. Much of it is going out of state. What should I be thinking about as a hospital or health systems, and what should I be doing to try to restructure myself so that my payments now can be these budgets, and what do I need to do to manage these patients?
First and foremost, I think there just is this raw acknowledgement that behavioral health, in particular substance use disorders, if you're in any total cost of care arrangement today or plan to be, is one of the leading causes of driving that up, and not in the substance use disorder purchasing service set, but in comorbidities that go untreated as a result. And so, I mean, workforce is a huge issue. We do have a behavioral health workforce shortage, so that puts pressure on finding the right providers and the right partnerships in your community that exist or don't exist. And if they don't exist, that might be technology, and or training your primary care staff and your ER staff and your other physicians in your community, around these issues. I mean, so much of depression is now dealt with in primary care. 5 or 10 years from now, the bulk of substance use disorder is also going to be dealt with in primary care. And so if you're not out front of that wave, you're going to be behind it. And if your primary care doctors are resistant to that, it's going to take some education and some training. And obviously, as the incentives shift, as we see more about the data on how these costs are driving. But I think the workforce issue, solving the technology challenges of if you have community-based providers that aren't linked to your EMR, and they're doing clinical behavioral health services, and you don't know what's happening over there, and you're doing their diabetes and heart disease, cancer over here. I think that's a core challenge. So finding those partnerships and figuring out how to build those bridges, whether that's through mergers and acquisitions or joint ventures or what have you, those clinical assets are very valuable and have been undervalued in our communities for a long time. And then the other thing that I think is really, really important for health systems is just to get assertive. Like, we have been so passive, waiting for end stage addiction to present itself when somebody is fully ready. And even when that happens in our emergency rooms, we still don't have a good answer for them, and we don't have a good pathway. And it's like somebody has to be ready to want to get addiction recovery services. And that is just not how we approach any other health condition. We do not tell somebody with diabetes they have to be ready for treatment in order to assertively try to engage them in some sort of early intervention, prevention, screen, wellness, whatever it is. And so we really have to flip that paradigm that we just sit back and wait till somebody is at end stage addiction to present itself for treatment.
And you and I were on a panel for an employer coalition in Florida, and one of the things that really struck me in Karen Van Call, who leads that coalition statements, was that when she speaks to her employers, this doesn't register as a blip, and yet the data are abundantly clear that the prevalence of substance use disorders is significantly higher than reported, because a lot of it that goes underreported. But again, as you look at the numbers are really quite significant. And so how in the world is that possible? Now, I'm suspecting that in part it's because there are health plans that out of an excess of interpretation of statutes, purposefully redact diagnosis codes and other identifiers that could link an individual plan member to a mental health or a substance use disorder or behavioral health condition. Maybe that's it. I'm puzzled by this because ultimately the employers are the ones that are bearing the brunt of this 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 epidemic, and they're bearing it in the cost of the care that they pay. And we saw the stats from Eric Bailey from Anthem. They're bearing it in productivity loss, and we also know that when people go through appropriate recovery from an addiction, they could be your most productive workers that you'll ever have. What are we missing? What do we need to tell employers? What do they need to do to open up this box, which clearly seems at this point quite opaque?
Yeah, I mean, there's two main issues. The first for me is just fundamental. I don't really believe people are actually looking. And if they are looking, they're not looking holistically. So they may be looking at like opioid treatment or looking at opioid use disorder diagnoses. The problem with that is it's good that they're looking. The problem is that's 10% of the substance use population. 2.5 million Americans have an opioid use disorder in this country. Certainly that is the substance use disorder driving mortality. But the substance use disorder that is driving total cost of care and exacerbating the health system, bar none, is alcohol use disorder. It always has been, and it always will be, and until we get our arms around that. And it's 4-to-1, 5-to-1, depending on the community that you live in terms of prevalence. Certainly methamphetamine, cocaine, and other substances are on the rise. Employers were the ones who innovated for EAPs because of alcohol use disorder. Employers have known about alcoholism for years, and we have carved it out. This is kind of the part of it. We've carved it out and kind of separated it and given it to somebody else, priced it in, if you will, and not really had the tools in the toolbox to address it. So I would say in the context of most conversations that I'm in, it's because they are only looking at opioids and not looking at substance use and mental health more broadly. But B, there is some regulatory privacy issues with their data sharing agreements, or there is some challenges with a carve out operating these services, and so they're not necessarily seeing it. And the other flaw that they don't look at total cost of care. They're just looking at their behavioral health spend. And what we know about the 20 million Americans with substance use disorder, less than 10% of them are getting any treatment whatsoever. And so just because people are not getting the care doesn't mean they don't need the care. And so demand and need are two different things. And people need to understand that if we actually drive up demand, we're gonna reduce the healthcare burden of all those people who don't think they need it. And that's what the numbers are showing. And so we need to kind of flip that paradigm that it's not just about utilization claims data. This is about total cost of care, and diagnosis, has to be the frame we look at this through and in a broader substance use context.
Well, the good news on that front is we're pretty close to having some results that we'll be able to share more broadly, and I think it's at least the early numbers I've been looking at show exactly what you were saying, with that those who have what you can call data confirmed substance use disorders have costs that, let's call it a median of $8,500. Those who we know have a substance use disorder but don't necessarily have a lot of evidence in claims data of substance use disorder, when you look at the combination of other conditions that they have, guess what? You get the same number. So to your point, you can't be blind and think, well, it's just this subpart of the population. for whom we have evidence that no, there's an entire other swath of the population for whom you don't really have any hard evidence that they have, but you have indicators that they have substance use disorders. And then the bulk of their cost is in all of these other medical conditions whose overall treatment is exacerbated because of the underlying substance use disorder. So I think we're really close to being able to come out and tell employers and payers, hey, this is what's going on in your population. And to your point, you're just not looking in the right place. Well, Greg, look, I know we could go on for many more hours on this topic, but unfortunately we have to cut it off for today. But we'll be back when we have numbers that we can look at, discuss, and share with everyone.
Awesome. Well, thanks, Francois, and thank you for everybody at Signify for all the work they're doing on this issue.